What's up, Ninja Nerds? In this video, we're going to be talking about atrial fibrillation. This is an extremely important topic that every clinician should know. So before we get started, I completely urge you guys, down in the description box, we have links to our website. On our website, we have comprehensive notes that cover everything that we're going to talk about in this lecture and additional topics that will help you, along with references and citations. We'll also have drawings, illustrations of the board before everything's drawn out as a template to follow along, and then the end product. So go check that out. If you like this video, if you benefit from it, please hit that like button, comment down in the comment section, and please subscribe. Let's get into it. All right, Ninja Nerds, let's get to talking about the potential causes of atrial fibrillation. Now, atrial fibrillation is basically, it's an arrhythmia. It's a supraventricular tachyarrhythmia, meaning that the arrhythmia originates from some irritability or reentrant circuit above the ventricles, and it causes this classic irregular rhythm. Now, with atrial fibrillation, we actually, if we're being very, very picky, there actually is no complete identifiable cause. There's what's called risk factors. We're going to use the term causes, but do remember, if we're being very, very picky or technical, they're actually risk factors. And there's two different types. There's cardiac risk factors and causes, and there's non-cardiac causes or risk factors. Let's first focus on what are some of the actual intrinsic cardiac issues that can lead to this supraventricular tachyarrhythmia that causes an irregular rhythm and tons of complications. The first thing that you want to think about is really atrial fibrillation is due to anything that stretches the myocardium, causing it to kind of dilate or hypertrophy. Anything that causes ischemia, decreased oxygen to the myocardium of the atria. Anything that causes inflammation of the atria or near the proximity of the atria, right? And anything that causes an increased kind of sympathetic nervous system kind of stimulation onto the atria, because that causes a lot of calcium loading and agitation to the atria. So what are those things? Well, cardiac issue-wise, someone think about what causes stretching of the myocardium. What if somebody has congestive heart failure? Their muscles are really floppy and flabby and they're causing stretching and distension of the myocardium, not just of the ventricles, but also of the atria. That could be a potential cause. So think about congestive heart failure. And again, this is by increasing the stretch of the myocardium. That may lead to atrial dilation. That may lead to atrial hypertrophy. But either way, it's changing the morphology of the atria. That's a potential trigger. What else? What else is something that can increase the stretch of the myocardium? What if somebody has a disease called dilated cardiomyopathy? You ever heard of that one? So cardiomyopathy, they get really thin, very floppy, very ballooned kind of ventricles, and it can even involve the atria a little bit. So we can say a cardiomyopathy, particularly dilated cardiomyopathy, we'll abbreviate CMP, right? And so again, this is through that mechanism of an increased stretch, all right? This one is again, increasing the stretch, causing the dilation of the ventricles and potentially the atria. Okay, what else? What if I have something that actually causes some irritation of the mitral valve or problems with the mitral valve, or maybe the mitral valve isn't working very well? And maybe it's stenotic, and less blood flow is going from the atrium to the ventricles, and then more volume is in the atria than you desire. And so the atria starts ballooning up. What's that called? Mitral stenosis. So sometimes if you have certain types of valvular diseases or disorders, and the most particular one is mitral stenosis. Think with me here for a second. Imagine I have stenosis of this mitral valve. The atria is trying to be able to contract and push blood from the atria down to the ventricles. But you have this stenotic valve not letting as much volume go from the atria to the ventricles. You know, the atria doesn't really push too much of the blood down during the cardiac cycle. What, maybe 20-30% from the atrial kick? But still, that's volume. So 20 to 30% of the blood can kind of stay within the atria. And that can cause the atria to kind of stretch a little bit. And as it stretches and dilates a little bit, what can that do? That's enough to potentially trigger what? An atrial fibrillation issue. So mitral stenosis may lead to some dilation of the atria or stretch of the atria. Makes sense? To a less common degree, you may get some of the same issues with regurgitation. It's just less common. Okay, let's write that down. Less common in that sense. but it's a potential. But I really, really want you guys to remember mitral stenosis, okay? So we got CHF, dilated cardiomyopathy, and valvular heart diseases, particularly mitral stenosis, all of them kind of working through the same kind of process where they're really stretching the atria, stretching the ventricles, causing remodeling of the actual myocardium, right? What else? What if I actually just jack up parts of the atria or the ventricles because I have less oxygen being delivered to them? I have them undergoing ischemia. What could that be due to? You know, if someone has very severe coronary artery disease, or maybe they have a past history of an MI or they had an MI, if you have some type of ischemia, let's say that that area is ischemic or it infarcts, now tissue in the atria is going to have to undergo remodeling near that area. And that ischemia could trigger those atria to start developing ectopic foci or reentrant circuits nearby, causing an atrial arrhythmia. Okay, so but this is by the mechanism of ischemia, right? So less oxygen, maybe even to some degree, infarction. What else? What else can we think about? Well, what if I actually, again, kind of cause like some inflammation of the myocardium? I really inflame it. I agitate it. Maybe I have some antibodies that are attacking it. Maybe I have some immune system cells that are attacking it. Just for some reason, right? And I cause a lot of inflammation of like the valves, or I cause inflammation of the atria, or I cause inflammation of the endocardium, or maybe even I involve the myocardium itself, but I'm causing massive inflammation. You know, there's a condition called rheumatic fever that can then lead to rheumatic heart disease. So rheumatic heart disease could be a potential trigger of someone developing atrial fibrillation due to the massive inflammation of valves. Sometimes what rheumatic heart disease will do is it can actually lead to mitral stenosis, and then mitral stenosis can lead to atrial fibrillation. Or you can have rheumatic heart disease that causes enough inflammation, it's enough to agitate the atria, and again, potentially trigger atrial fibrillation. But again, inflammation sometimes may be related to mitral stenosis, which then leads to that. But either way, we got CHF, dilated cardiomyopathy, valvular disorders, particularly mitral stenosis, coronary artery disease or MI, and then we got rheumatic heart disease. What's the last one? Big one that I want you guys to remember. Sometimes if you have high blood pressure, right? So let's say here you have high blood pressure, right? And so your left ventricle is having to work harder. It's having to contract more and contract more and contract more. And by some unknown kind of mechanism, maybe it's just via the hypertrophy. So you have something like hypertension. That hypertension leads to left ventricular hypertrophy. And maybe that hypertrophy over time is enough to be able to cause some type of hypertrophy of the atria by some way. Or it just causes some remodeling of the atria by some way. That may be enough to cause the atria to become irritable enough and generate these abnormal electrical activities. Okay? So again, big kind of intrinsic cardiac disorders that I really want you to remember to take away here: CHF, dilated cardiomyopathy, mitral stenosis. All of these kind of really causing dilation, stretching of the actual myocardium of the heart. CAD-MI potentially causing ischemia to the heart. Rheumatic heart disease leading to inflammation, and hypertension kind of leading to some hypertrophy and other associated kind of issues where you might cause the atria to undergo remodeling or hypertrophy itself. These are the cardiac causes. Now let's talk about the non-cardiac causes. All right, so we talked about the cardiac causes. Now let's talk about the non-cardiac causes. In the same way, you have to remember the potential triggers or causes of someone developing atrial fibrillation, those atria abnormally firing, is by mechanisms of some type of increased stretch, whether that causes dilation, whether that causes hypertrophy of the atria and the ventricles, whether it be due to inflammation, whether it be due to some type of ischemia, or whether it be due to increased sympathetic nervous system activity. Some of the ones above were inflammation, were ischemia, and were stretch. What about these ones down here? Non-cardiac causes that can cause atrial fibrillation could be something wrong with the lung. You know, and patients who have like COPD, or who have pneumonia, or who maybe have an acute onset pulmonary embolism. What can all of these things potentially have in common? If the lungs aren't working well, they're supposed to take oxygen, bring it into the alveoli, push that into the blood and get rid of CO2, right? That's the job of the lungs, to be able to do that. If there's some pathological process of the lung parenchyma, such as in COPD and pneumonia, the ability to get oxygen into the blood is going to be decreased. But the other aspect is that you need blood to be able to flow to that area to pick up the oxygen. So if by some reason there is a clot in the vessel that's supposed to be able to pick up oxygen and take it to the tissues, if you have something like a pulmonary embolism, you may be able to ventilate appropriately, but the oxygen might not be able to get into the blood and pass that occlusion, right? But either way, through any of these mechanisms, whether it be a problem with the lung or a problem with perfusing the actual area to pick up oxygen, this is going to lead to low amounts of oxygen. Now, this isn't causing like ischemia of like the myocardium, it's causing hypoxemia that could potentially cause ischemia, but there's low oxygen leading to this hypoxemia effect, and that might be enough to be able to trigger the atria to become irritable and then start causing that abnormal ectopic foci or reentrant circuits. Okay? So we got these particular causes. We got lung causes, we got the cardiac causes. What are some other non-cardiac causes? All right, this one's interesting. In someone who has what's called thyrotoxicosis, you're like, what the heck? We call them thyrotoxicosis or hyperthyroidism, one or the other. What's the issue? They're just popping out tons of T3, popping out tons of T4. So they have hyperthyroidism or thyrotoxicosis. What's the issue with thyrotoxicosis and atrial fibrillation? Believe it or not, the hyperthyroidism, T3 and T4, increases the beta adrenergic receptor stimulation. If you make the beta 1 adrenergic receptors more sensitive to epinephrine and norepinephrine, what's going to happen? You're going to get an increased sympathetic nervous system type of effect. What was one of the potential triggers for atrial fibrillation? Increased sympathetic effect. Boom, we good. All right, what else? This one, they love to throw this on your exams, okay? It's just an important one that you have to remember. If someone decides to go out and have an all-night bender, okay, and just drink tons and tons of alcohol. So they drink tons and tons and tons of alcohol, and they have an all-night bender. There's something called holiday heart syndrome that can develop. Now, the mechanism by which it does this isn't completely known. There's ideas. But whenever someone goes out and they just have an acute binge kind of alcohol kind of drinking event, the increase in the alcohol within the body can do a couple things. One is it can increase like the reactive oxygen species, and that can lead to inflammation. That inflammation may be something that can cause irritation and agitation to the atria. The other thing it does is it kind of increases the sympathetic nervous system effects on the heart. So then you got kind of an increased sympathetic effect on the heart. And if you get this increased sympathetic effect on the heart, that also is a potential trigger. So there's these kinds of thoughts that maybe alcohol itself may also just have some type of cytotoxic or hurting kind of effect on the heart, but it may be through reactive oxygen species leading to inflammation or increased sympathetic nervous system activity. Another thing is, if you drink tons and tons of alcohol, it can alter your electrolytes. So there may be electrolyte abnormalities. And this may be in potassium and this may be in magnesium, which are two particular cations that are important for electrical activity of the heart, okay? And this may be because of vomiting associated with it, or because of the alcohol not having lots of, particular like nutrients, micronutrients that we need there. Okay, so big things. Lungs, like COPD, pneumonia, acute PE, thyrotoxicosis, holiday heart syndrome. Please don't forget, son of a gun, please don't forget holiday heart syndrome. That's probably gonna show up on your exam. Okay, what's the next one? The next one is actually very interesting. You know, there's a condition where you can have like a tumor of your adrenal medulla. It's called pheochromocytoma. So it's a tumor on the adrenal medulla, and it just spits out epinephrine and spits out norepinephrine. That's tons of what? Catecholamines. What do these things do? Bind onto beta 1 adrenergic receptors. What does that do to the heart? It causes lots of calcium influx and cation loading. That's enough to agitate the atria, potentially cause it to go into a atrial fibrillation type of rhythm. So this is going to really increase the sympathetic nervous system activity. Man, we good. All right, you decide to go and do some booger sugar, right? Some cocaine or methamphetamines of some kind. And not good. Why? Because guess what these drugs do? Coke and methamphetamines, they act as sympathomimetics. So they bind on to the different receptors that epinephrine and norepinephrine would do. And they increase your sympathetic nervous system activity, causing more cation loading, more irritation of the atria. Boom, we good. What else? You know, this is another one, but this is like a good thing for an acute onset. So this can be an acute onset. This other one could be an acute onset. You know, if someone has like a really bad infection, like a sepsis, they have a really bad sepsis, okay? In that septic kind of response, whenever there's vasodilation, capillary permeability, infection causing fever, your sympathetic nervous system gets hyperactivated because it's a protective response. When you're septic, your blood pressure drops, you start to become kind of febrile, you start to have a ton of issues. So your body tries to go into this fight or flight mode in response to that stressful event. And so sepsis can increase your sympathetic nervous system activity, particularly if someone's going into a hypotensive state. It'll try to increase your heart rate, increase your blood pressure so that you can kind of counteract the negative effects from sepsis. The next thing that I want you guys to think about here is if someone actually goes and gets surgical procedure. So sometimes if there was some kind of surgery, post-op, this can cause just generalized stress on the body. And that post-op stress may be something to trigger a catecholamine response. It's just a natural thing that can happen. If it was a significant surgery and there's just a significant amount of post-op stress from a very invasive kind of procedure, that may be something that caused your sympathetic nervous system to become super hyperactive and just push you into a new onset AFib or atrial fibrillation in general. The last thing that I want you guys to remember is electrolyte abnormalities. Let's actually squeeze this one in here. So sometimes if someone has any electrolyte abnormalities, for example, if they have two particular cations in the blood that are low, these really alter the electrical activity of the heart. And this is one of the other causes. So there's a couple other causes. We said inflammation, low oxygen, some type of stretch, dilation, hypertrophy, increased sympathetic activity. The last one that I want you to remember is electrolyte abnormalities. So if there is low potassium and low magnesium, this can alter the electrical activity of the heart in a way that it could potentially push someone into an atrial fibrillation or push them into some kind of supraventricular tachyarrhythmia. So that's, again, a big thing to think about. This covers all of our cardiac and non-cardiac causes or risk factors. Let's talk about how these actual things lead to the pathophysiological and clinical features and complications associated with AFib. All right, Ninja Nerds, let's talk about the pathophys. So again, we talked about all the causes and what those causes can do. Let's test your memory as well as adding in how these things actually do this, right? So go back. What were some of the triggers? We said there was a bunch of them, right? The first one that I wanted you guys to remember is if there was some kind of increased stretch on the heart. Right? So increased stretch on the heart could have been from CHF, could have been from dilated cardiomyopathy, could have been from mitral stenosis, right? Causing that actual valvular narrowing and leading to the ballooning and dilation of the atria. Could have been things like that. What else? There could be something that's causing some kind of inflammation of the actual myocardium. So what if there's inflammation? Maybe that's in something like somebody has some rheumatic heart disease of some kind. So if they have rheumatic heart disease, that's causing a massive amount of inflammation. Or what if they had like that holiday heart syndrome and they had the cytotoxic effects from the ethanol, or there was a lot of reactive oxygen species that were being produced and that was also causing a lot of inflammation, okay? What else? Well, not only could it be inflammation, but what if it's due to some type of like low oxygen? What if there's low oxygen being delivered to the myocardium? For some reason, maybe it's because there's a clot within the coronary vessel. Maybe it's because there's actually some type of decreased oxygen coming from the lungs. Could be things like that, right? So if there's a decreased oxygen delivery that is going to the lungs, and again, coronary artery disease, MI, COPD, pneumonia, acute pulmonary embolisms, these could be potential causes. What else? What if it's not just due to increased stretch? What if it's not just due to increased inflammation? What if it's not just due to some type of decrease in oxygen delivery by some mechanism? What if it's due to an increased sympathetic nervous system activity effect? So there's increased sympathetic activity. So if there's increased sympathetic activity in situations such as what? If someone has thyrotoxicosis, if they're drinking tons and tons of alcohol, if they have a pheochromocytoma, cocaine, methamphetamine, septic reaction, post-op, all of those things are potential triggers as well. And what's the last one that I mentioned, kind of squeezing that in at the last minute? Electrolyte abnormalities. What is the two particular types of electrolyte abnormalities that I really want you guys to remember? Hypokalemia and hypomagnesemia. All of these things can just cause a significant agitation to the myocardium. And if this myocardium becomes agitated enough and starts having some reason that it needs to remodel, it becomes agitated enough that it starts to want to fire, it can start generating some abnormal electrical activity. And it may generate this abnormal electrical activity in two ways. You may form these areas, multiple areas in the myocardium of the atria, that you have these things called ectopic foci. And they start firing off electrical activity. And this creates a arrhythmia. Or it could be due to, what else? What if you have some type of remodeling in a way where you have an alpha pathway and a beta pathway that's kind of generating that we talked about in our arrhythmia lecture, the overview one. You could develop these things called re-entrant circuits. And these re-entrant circuits can actually start to form. And whenever they form, they can fire off electrical activity off of that. And again, that can also lead to an arrhythmia. The same concept can exist. So again, thinking about how all of these triggers, whether it be cardiac or non-cardiac causes, this may produce what? Some type of irritable foci, causing these ectopic foci to fire, or there could be something from outside of the heart that's influencing the atria to develop ectopic foci or re-entrant circuits and then causing these abnormal electrical activity coming from the atria, a supraventricular tachycardia, which again we call atrial fibrillation in this case. That is the big concept. So again, without going into all the things, because we actually don't know exactly how these mechanisms produce this process within the heart. We just know it causes them to become irritable, triggerable, maybe undergo remodeling process. And then by that process, they develop ectopic foci or re-entrant circuits. All right, Ninja, so now we have to understand basically how does atrial fibrillation lead to the particular clinical manifestations and stuff like that, right? So the first thing I want you guys to understand is let's pretend, right? We have one of the causes and the triggers, and we have these areas of ectopic foci that are generating these abnormal electrical activities, and they're starting to just fire, right? But you have to remember, who is the pacemaker of the heart? Who's the one that says, hey, I generate the sinus rhythm and I send electrical activities down to the AV node, telling the AV node to say, oh, here's the firing from the atria, send this down to the ventricles via the bundle of His, the bundle branches in the Purkinje system. That's our SA node. He's the one that generates our sinus rhythm. If you have areas other than the SA node that are actively firing because of all the triggers we talked about, they're going to start firing, whether it be ectopic foci, whether it be re-entrant circuits, and they're going to start interfering with the normal sinus pathway. In such a way, let's pretend here that you have this one ectopic foci. It's close. It fires. It gets to the AV node before the SA node and all these other ones. And so it's able to trigger, a QRS complex because it goes down to the ventricles. Then after that, you have the next one. It comes right after. But it comes just a little bit later, so you get a little bit of a delay. Boom, you get your QRS complex because it sends it down to the ventricles. Then you get the other one, but that one comes right behind it. And then you get the other one, and that one comes right behind it. You start getting this variation in the rhythm, but it's not coming from the SA node. It's coming from these other ectopic foci or re-entrant circuits in the atria. This causes there to be no visible P waves. So therefore, it's not a normal sinus rhythm. You also cause an irregular rhythm, because now I have variations in my R to R interval because of different ectopic foci hitting the AV node and then telling the AV node, hey, send this down into the ventricles. The problem with this is that you can get variations in heart rate. Sometimes you can have heart rates that are really fast, greater than 100. Or sometimes you can have lower heart rates that are less than 60 beats per minute. And we'll talk about the different classifications of AFib. The thing is, is that sometimes you may be completely asymptomatic. You may have no symptoms and not even know that you have atrial fibrillation or an irregular rhythm. But sometimes, if it's fast enough, if it goes just a little bit fast, and these abnormal electrical activity causes palpitations, sometimes that could be something that we can experience. So palpitations may be an experience. Maybe there's shortness of breath. Maybe there's fatigue. So there is sometimes common symptoms, and these tend to be some of the most common symptoms that you can see with atrial fibrillation, that being palpitation, shortness of breath, or fatigue. Sometimes you may even get a syncopal episode as well. So what if the heart rate's going really fast though? And I mean fast. Like what if the heart rate's starting to tack away? You're getting greater than 150s. On your heart rates. Now, you guys remember our equation that it says cardiac output is equal to heart rate multiplied by stroke volume, right? So correlationally, you would say, oh, if there's an increase in heart rate, it should increase our cardiac output. You'd be correct. But if the heart rate is so fast that you're not giving the ventricles an adequate amount of time to fill, so that way it has a good end diastolic volume, and then when it contracts out a good amount of volume, you could potentially lower your cardiac output because you're lowering their filling time. So effectively, very, very high heart rates, greater than 150 generally, can lower your end diastolic volume. If you lower your end diastolic volume, you can lower your stroke volume. And if you lower your stroke volume, you can lower your cardiac output. Why is that a problem? There's another equation. It is that your mean arterial pressure is equal to your cardiac output times your systemic vascular resistance. Right? So if you start actually doing what? If you start increasing your cardiac output, you should increase your MAP. If you lower your cardiac output, you could potentially lower your mean arterial pressure. And so as a result of that, this may produce hypotension. And since it's coming from the heart, this can lead to a cardiogenic shock. So this is one of the complications that could potentially present. It's usually when the heart rate gets really, really fast that it's a possibility. But again, sometimes it could be completely asymptomatic with just some minor palpitations, fatigue, maybe some shortness of breath, maybe some syncopal episode. If it gets really, really fast to the point where it alters your cardiac output, it could lower your blood pressure and cause cardiogenic shock. Okay? Now, here is the part where you gotta be on point, because this is going to be the big thing. Sometimes patients will never have this issue of cardiogenic shock, of really fast heart rates. They might not even have any symptoms. And you know what happens? All right, ready? If the atria is having these ectopic foci or reentrant circuits, and it's causing these weird depolarizations and contractions, here's the big thing. These, abnormal electrical activity produces inadequate atrial contractions. Now, go back to what you guys remember from the cardiac cycle. In the cardiac cycle, blood from the atria naturally flows down to the ventricle passively. Anywhere from 70 to 80% is passive. Where's the remaining 20 to 30% coming from? The atrial kick, right? So the atria at the end of that kind of period where it's filling, it contracts and squeezes down the remaining 20 to 30%. When you get this atrial quivering from the atrial fibrillation, inadequate electrical activity, it causes inadequate atrial contractions. You decrease the atrial kick. And so what happens here is you cause more blood to kind of stay within the atria. It doesn't move down to the ventricles. What is that called when blood stays in one area longer than it should be? Stasis. So then you get this increased stasis. What's Verko's triad? There's a stasis of blood flow, endothelial injury, or hypercoagulability. It increases the risk of a clot. I have a potential factor here, and that is going to lead to a blood clot. If I form a clot in the atria, or I form it on the valve, guess what could happen? For whatever reason, maybe you convert. Sometimes people with atrial fibrillation, they just naturally convert, and then their heart starts beating on its own regularly and you get good contractions. Now the atria might be strong enough to pop that clot off. Or for some other reason, you potentially have an increased stressful event and your heart starts contracting more and you pop that clot off. If I pop this clot off, it can then flow through the systemic circulation up to the brain, down through the descending aorta, and just go and embolize into multiple different organs. And the problem with this is that you can get emboli that can hit multiple different organs. What are the organs that we should be very, very much so thinking about? The brain. Sometimes one of the first signs is a cerebrovascular action, so developing an ischemic stroke. Another one is the spleen. You can develop a splenic infarct. Sometimes it's the kidney, and so you can develop a renal infarct. And sometimes it's the actual gut, particularly like the small bowel, large bowel, and you can develop what's called acute mesenteric ischemia. And so thinking about these, some patient may come in with abdominal pain. Someone may come in with an increased BUN creatinine. Some patient might come in with some pain in their left upper quadrant and maybe some other issues with their actual CBC. Some patient may come in with neurodeficits. And then you have to go back and say, why did that happen? Oh, they had atrial fibrillation and they weren't anticoagulated for some reason, or we never knew it. That is the big thing to think about. So now we have an understanding of the causes, how those causes can lead to the pathophysiological mechanisms that lead to the clinical manifestations or complications. Now let's talk about some classifications and diagnostic tools. All right, engineers, let's talk about diagnosis. Now, before we actually start going through all the diagnostic tools of imaging and labs and so on and so forth, it's important that we actually develop this classification of atrial fibrillation. This is something that you'll definitely have to know, not just for your exams, but also in your actual clinical practice. It's important to understand when this terminology is getting thrown around, what the heck it means. The first one is sometimes we can describe atrial fibrillation with respect to how it's affecting our hemodynamics. So it's important to understand that terminology. And so when we say they have a hemodynamically unstable atrial fibrillation, what does that mean? Because not only is it important to know what it means, but it determines our treatment plan for it. So hemodynamically unstable refers to particular things such as maybe them having low blood pressure, so being hypotensive, maybe them having something like pulmonary edema, which this can happen especially if they go into that cardiogenic shock state where their EF is not actually adequate enough and blood starts kind of backing up to the pulmonary circulation in that cardiogenic shock state. Or they have an altered mental status. Or lastly, they have severe chest pain. So these are things to think about. So if a person has any of these particular types of things, such as hypotension, pulmonary edema, altered mental status, or chest pain, we call that hemodynamically unstable atrial fibrillation. And usually those patients get fit into a category of like electrical cardioversion of some type. Hemodynamically stable means that they have none of the above issues. None of above issues. Pretty simple, right? We don't have to be too crazy on that one. They have normal blood pressure, they have no pulmonary edema, they have normal mentation, and no obvious significant refractory chest pain. Boom, done. The next thing that you have to be able to talk about, because we talked about this a little bit back there, is that atrial fibrillation, right? If somebody has atrial fibrillation, they have all those ectopic foci that are firing, and it's firing really, really fast, and a lot of it's hitting the AV node, and a lot of it's actually going down to the ventricles, and the ventricular rate is going faster and faster and faster. We're starting to get greater than 150 beats per minute, greater than 100 beats per minute. They can start having rapid ventricular conduction. And so we say rapid ventricular rate, or RVR, can be a type of AFib. So sometimes patients can have what's called AFib with RVR. And that just means that their heart rate is getting really fast, particularly their ventricular rate is what we're talking about, not the atrial rate. The ventricular rate is getting fast, greater than 100 beats per minute. But sometimes you can have these reentrant circuits or not many ectopic foci, and they're not firing as fast or as frequent that it's causing the AV node to send tons of conduction down into the actual ventricles, and so they're not having a very fast ventricular rate. And so we call that AFib with a slow ventricular rate or conduction. And so that's whenever the heart rate is usually less than like 60 beats per minute. Okay, so that's important to remember. You can have AFib with a normal rate, you can have AFib with RVR, where it's greater than 100 beats per minute, or AFib with a slow ventricular rate, where it's less than 60 beats per minute. So now we have hemodynamic instability type of AFib, hemodynamically stable AFib. We have AFib with RVR, AFib with SVR. All right, so the other way that we can classify AFib is based upon onset. Did it just start? Have they had AFib for a long period of time? Is this a type of AFib that even though we've tried to convert them, there's no need to even convert them at all anymore because they have this consistent, like permanent AFib. And so that's an important thing to differentiate. So we have what's called new onset atrial fibrillation, meaning that the atrial fibrillation developed less than 48, sometimes we even say 72 hours ago. Paroxysmal, meaning that it developed within less than 7 days. Persistent, meaning that they've had atrial fibrillation for greater than 7 days. Long-standing atrial fibrillation is they've had known AFib for greater than 1 year. And lastly, permanent AFib is when someone has persistent AFib, which is usually, again, greater than 7 days, somewhere between 7 days and a year. So it's greater than 7 days without any attempt to cardiovert the patient to normal sinus rhythm. That is how we define permanent AFib, okay? So again, quick recap: new onset, less than 48 to 72 hours. Paroxysmal, less than 7 days. Persistent, greater than 7 days. Long-standing, greater than a year. Permanent is they're greater than 7 days, but there's no attempt to be able to convert them to normal sinus rhythm, okay? That is how we define and classify it in that category. The last classification of AFib is, does it have valvular involvement? And this goes back to that mitral stenosis. So valvular AFib, meaning that is there evidence of mitral stenosis, or is there do they have some type of valve? Do they have like an actual mechanical valve? So that could be another potential thing, because again, this determines what kind of anticoagulant they need. And then non-valvular is obviously there's no mitral valve involvement or mechanical valve. Okay, so that is how we define these. So we got how we define them again, and what particular categories. We got hemodynamic stability, we got ventricular rate, we got onset and duration, and mitral valve involvement. Now let's talk about some of the tests that we utilize to diagnose and aid in determining the risk factors or causes for this condition. All right, so now we have to start trying to diagnose atrial fibrillation. The best test that you could potentially use that's the cheapest, it's the most non-invasive, it's a quick test, is to see what their EKG tells you. Do they have evidence of atrial fibrillation on their EKG? So looking at their EKG, I want us to kind of not focus particularly on what the EKG would look like. We'll look at some examples in a little bit, but I want you to notice to take a look at V1. V1 is going to be one of the leads that I really want you to focus on, because that tells you about what their atrial activity looks like. If you don't see anything in V1, then you can go ahead and take a look at 2, 3, and AVF, because that also will give you some activity of what their atria looks like as well. So that's one thing I want you to look at. But what can an EKG tell us? Well, the first thing it can tell us is, do they have atrial fibrillation, right? Because that might be one thing right away. The other thing I think is really important is sometimes there's a very dangerous condition. We talked about this in our arrhythmia video. If someone has AFib with Wolff-Parkinson's-White syndrome, look for very fast rates. So you look for wide complex tachycardia generally, you look for this irregular kind of rhythm, and you look for rates that are close to 200 beats per minute. That might make you think about that. So look, is there any Wolff-Parkinson's-White syndrome that could be present? The other thing, think about what were some of the potential causes of somebody having atrial fibrillation. Could it have been that they had a recent myocardial infarction, or they had coronary artery disease? So look to say, can I rule out that they don't have any ST segment elevation or ST segment depression? The other thing is, do they have any left ventricular hypertrophy? Because what was another potential trigger? Hypertension, and hypertension can cause LVH. Okay? So you utilize your EKG. Here's the thing though, here's what you really want to realize. Sometimes you can get an EKG on somebody and they may not be in AFib right now. They may be in normal sinus rhythm or have no obvious AFib. What can I do outpatient that'll track their electrical activity over maybe a certain amount of time? I can do something called a Holter monitor. So the other thing that I want you guys to remember is that if you do outpatient continuous studies, you may need to do something like a Holter monitor. That's kind of like your gold standard. They can also do loop recorders. But what if you're inpatient? What if the person's really, really sick? They have something else that's making them have to go to the hospital, and you have to do inpatient continuous investigation of their electrical activity of the heart. You do telemetry. So you hook them up and you have them connected to the actual interface, the computer, and it'll kind of give you an electrical activity of their heart over their entire stay when they're at the hospital. So sometimes you may have to do what's called telemetry. But these are big, big things that are going to be really important for your exam. Continuing, just because you do a one-time EKG and it's not there, doesn't mean that they have AFib. It just might not be that they're in AFib at that moment. All right, so what's the next thing we can get? We can get a chest x-ray. Why would we get a chest x-ray? Chest x-ray could tell us a little bit about things. Generally, when someone comes in with like palpitations or shortness of breath or they have fatigue, it's not a bad idea to get a chest x-ray. There could be other reasons of why they have that fatigue, that shortness of breath, those palpitations, anything like that. So it's not a bad idea. Plus, it also may key us into as to what's the trigger for this AFib. If they have a new onset AFib, what if it's because I get a chest x-ray and I notice that they have pneumonia? Right, so maybe you want to rule out pneumonia. Maybe you want to see if they have pneumonia and that's the trigger. What if they have COPD? They have lungs that are hyperinflated. They have hyperlucent lungs. You can see that they have a flattened diaphragm. That's not diagnostic of COPD, but if they have tobacco abuse and maybe a chest x-ray that's suggestive of it, you have kind of an idea. What else? Well, the other thing that you could look for is, what if they have a big old heart? They got cardiomegaly. Cardiomegaly may key us in to say, ooh, they got some cardiomegaly. What if they have CHF? What if they have dilated cardiomyopathy? That could be a potential trigger as well. That could be something related to their atrial fibrillation. So it's not a bad idea to get a chest x-ray. So start off with an EKG, maybe diagnose it, continue it outpatient as a Holter, continue it inpatient tele. Tell us if there's any kind of other things associated with it. Chest x-ray, kind of ruling out other kinds of things that may be related to it, or just ruling out these conditions that you're trying to make sure it's actually AFib. What else? Next thing is we're going to get an echo. All right, so what else can we do? We got the EKG. We either diagnose it off the EKG, that one-time 12 lead, or we follow them on tele, we follow them as a Holter. Maybe we diagnose AFib. We also find out maybe some other reasons on their EKG that would suggest it was something. We get a chest x-ray to rule out like pneumonia, to rule out COPD, to rule out any kind of other kind of things that may be there. Also look to see if there's any obvious cardiomegaly. Then we can get an ultrasound. An ultrasound, particularly an echo. Now, I put TEE here. It's kind of like our kind of gold standard if you really wanted to get kind of an echo there. A TEE is actually going to kind of be best, but you could get a TEE or you could actually get a TTE, so a transthoracic echocardiogram. It doesn't really matter. They're both pretty good. Sometimes a TEE is a little bit better at picking up something within the atria, but either way, you can get a TTE as well. All right, what are we looking for in this? Well, the big things that you're looking for within this particular study is this can tell you a couple different things. First thing is it can tell you, is there any atrial thrombus? That's the first thing it can tell you. If you have an atrial thrombus, that is a big, big deal because that tells you, hey, there's a clot there. You got to be careful. If you try to convert them or if they go out into normal sinus rhythm or something happens, you can pop that clot off. You may have to start anticoagulating them right now. Or it can tell you if there's any mitral valve issues. So is there any mitral valve disorder of some kind? Maybe they have a mitral valve stenosis. Maybe they have a mitral regurgitation. Maybe they have a mechanical valve and they didn't know it and you didn't know it. And it wasn't in their history. Who knows? Or it also can tell us if there is any. It tells us the left ventricular ejection fraction, which is important because we want to know, what if their ejection fraction is really low? What if they have an EF of like 30 to 35% and I didn't know that they have heart failure with a reduced ejection fraction? Oh, that might be why this is also related to it. So that's something that it can also tell us. It also can tell us if they have any left ventricular hypertrophy, which again was something that we also are associated with atrial fibrillation, associated with hypertension. So again, getting a whole overall look at the heart is a great thing, but one of the big things to take a look at is there atrial thrombus, is there mitral valve disorders, is there left ventricular ejection fraction, like abnormality, what is it, and do they have any left ventricular hypertrophy, okay? And the last thing here, one more thing, is what's the size of the atria? So atrial size. The big thing is there any atrial dilation. Is the atria really big? If the atria are dilated, that is a big thing, and that might help to clue you in, oh, they never knew that they had atrial fibrillation, but they got a dilated atria. That could be diagnostic of atrial fibrillation, even though their EKG hasn't shown it, even though their Holter monitor at this point in time hasn't shown it, even though their inpatient telemetry hasn't shown it. So that's another thing too. So do they have an atrial thrombus is a big one. Do they have any mitral valve disorders? And is there any atrial dilation? Okay? So once we've done that, we have a pretty good idea if we need EKG, Holter, telemetry, and TTE, TEE. These are the most important studies that I want you to remember. You can order labs, you can order a chest x-ray, they just may help you in other particular ways. So for example, think about some of the particular causes. Go back to some of those. Is there any labs that may help me? It might not be diagnostic enough, but you know with someone who has heart failure, you can get a BNP, and sometimes if somebody's BNP is elevated, it may help you to think of, is there any CHF? How can I tell that? Correlate it with their echo. Does their echo show that they have obvious signs of left ventricular ejection fraction abnormalities, dilated ventricles, hypertrophic ventricles, anything like that? The other thing is, what were some other causes? Do they have any myocardial ischemia? Well, do their EKG show any ST segment changes? And what does their tropes tell us? Do they have any elevated tropes? Well, if their tropes are elevated, maybe they're having like some type of MI. That could be leading you into something. What else? Think about particularly some of the non-cardiac causes. We did our chest x-ray, right? What else could we do potentially thinking if there's like some type of pneumonia? I could do a CBC. I could do a CBC to look to see if there's any elevated white count. Maybe that'll clue me off that there could be potentially a pneumonia related to this. You can even get things like procalcitonin. Not great stuff, but you can correlate things with your chest x-ray. What else could I get? What if, oh, thyroid, that's a big one, right? I can get a TSH with reflex. So I'm checking the TSH to see what that looks like. If the TSH is really low, that means that the thyroid hormone's potentially high, and you check that T3, T4. So this may tell me about hyperthyroidism, which could be a potential thing that could be going on back there, right? What else? What if they're drinking a little bit? Go. You know, they had an all-night bender. They were drinking tons of alcohol. What else could I check? I could check a blood alcohol level. I could check their blood ETOH to see if that's positive, right? What if they've been they got a pheochromocytoma? So if they got a pheochromocytoma, you can do what's called check what's called their urine metanephrines and look to see if those are positive. You can also get an adrenal CT to see if there's an obvious mass within the adrenal gland. What else could I do? Well, if they're doing the booger sugar or they're doing something like that, you got to check that tox screen. So maybe doing like a urine tox screen also wouldn't be a bad idea to look to see if that's positive for any kind of cocaine, methamphetamine, or even like any metabolites of urinary alcohol. So there's a bunch of labs that you could utilize. Is it going to be helpful in diagnosing AFib? Not really. It might just help you to figure out what's the thing that could have been triggering the AFib. Okay? But the most important test, and I can't stress this enough, is the EKG and the echo. Those are the big things that we need to know. All right, Ninja Nerds, let's talk about the treatment of atrial fibrillation. So we've established the diagnosis of AFib. Now the next question is, okay, how do we go about treating this? And first things first, most important is what is their hemodynamic status? So it goes back to that classification. Are they hemodynamically unstable? What does that mean? To be hemodynamically unstable. Do they have hypotension? Do they have pulmonary edema? Do they have refractory chest pain? Do they have an altered mental status? Because if they do, it's a quick, easy decision. They're unstable. I'm not going to mess with all this other stuff that we're going to go through. I'm going to shock them, and then we'll deal with all of the other stuff a little bit later. So in an unstable state, I'm going to do what's called direct current cardioversion. So I'm going to hit them with some electricity, baby, shock the crap out of them, hope that sets them back into a normal sinus rhythm and allows for me to be able to, have a better control of their hemodynamic status. Now, that's that pathway. The other pathway is if they're hemodynamically stable, so they have normal blood pressure, they don't have any pulmonary edema, they do not have any altered mental status or refractory chest pain. That leads me to the first decision, which is to rate control these patients. And usually the two preferred agents of rate control that are quick is beta blockers and calcium channel blockers, but we'll go over those a little bit later. Now, after I rate control them to target a heart rate a little bit lower, maybe like desirably less than like 110, 100 beats per minute, the next thing I have to determine is this is primarily going to kind of control their rapid AFib. But the next decision I have to make is, are these patients at risk for developing an embolization of a clot that I don't know if they have in their atria, or potentially of developing a clot within their atria and then embolizing that? I need to determine their need for anticoagulation. We'll talk about that process in a little bit more detail, but that has to be the second step for two reasons. We want to reduce the risk of embolization, and second, it's going to play a role within the next decision, which is, am I going to stick with rate control and anticoagulation, or am I going to go to the third step, which is cardioverting the patient? So it's kind of like a nice bridge thing here, right? So the second decision is, do I anticoagulate the patient? Okay? And usually if they're getting admitted, you start with something like unfractionated heparin or low molecular weight heparin, and if they're going outpatient, you do like, or if generally, you can do something like oral anticoagulants. You can even do that inpatient as well. So we rate control them first. Second, we determine their need for anticoagulation. Now, here's the interesting thing. Sometimes, actually not sometimes, like 50 to 70% of the time, it's like that, 50 to 70% of the time, within, usually within 24 hours, these patients may do what's called spontaneous cardioversion, meaning that they convert themselves back to normal sinus rhythm without any kind of electricity or chemical induction process. So that is an important thing to remember. So sometimes they can spontaneously convert like 50 to 70% of the time within the first 24 hours of their onset. And so that's another thing, especially if it's an acute onset AFib. Now, after we again have rate controlled them, anticoagulated them, and let's say that they have not spontaneously converted back into normal sinus rhythm, let's say that they're still in their abnormal rhythm right now, we then have to make the decision, is it necessary, do I need to cardiovert this patient back into their normal sinus rhythm? If I do, I have to start taking into consideration cardioversion. And again, there's two types of cardioversion. We will talk about this in a little bit more detail, but there's electricity and then there's chemicals. So now I go to the third step, which is, do I consider cardioversion after I have determined their hemodynamic status and intervene in that way, rate controlled them first, anticoagulated them along with the rate control. If they did not spontaneously cardiovert into normal sinus rhythm and they're still in that AFib, I need to make the decision, do I need to cardiovert them? Okay, how do we make that decision? Well, it kind of depends upon how long this person's been in AFib and what's their risk of a stroke. So two factors determines kind of your need for cardioversion at that moment. Usually, if someone has been in AFib for less than 48 hours and they have a low risk of a ischemic stroke, you can just cardiovert them. It's unlikely, if it's been less than 48 hours and you definitively know that, and their CHA2DS2-VASc score kind of shows a low risk of stroke, you can say, okay, I'll cardiovert them. And then from there, you can cardiovert them. And again, there's two options. You can do this chemically, you can do it electrically. And then you can decide based upon their CHA2DS2-VASc score, based upon other associated risk factors, if I need to put them on oral anticoagulants for 4 weeks after I cardiovert them. So then you're going to cardiovert and then decide based upon their CHA2DS2-VASc, their risk factors, if they need to be anticoagulated for 4 weeks after they've been cardioverted. So that would be that pathway, all right? So you've rate controlled them, you've anticoagulated them potentially, okay, but if they spontaneously cardiovert, you have to consider cardioversion. If they've been in AFib for less than 48 hours, you cardiovert them, and then you have the decision of oral anticoagulation for 4 weeks continuously. Okay? Now, if they have been in AFib for greater than 48 hours, or you don't know, maybe it's not even known how long they've been in AFib, and they have a high risk of a cerebrovascular accident or an ischemic stroke, you have two options here. You can either see if they have a clot within their atria at that moment. How do I do that? Well, I can get a TEE, right? So I can get a transesophageal echocardiogram, a TTE, but either way I get a TEE. Let's say that it's positive. So it's positive for a left atrial thrombus. Worst case scenario, right? It's positive for a left atrial thrombus. Then what I have to do is, I have to do what's called, I'm going to do oral anticoagulation for 3 weeks, empirically, okay? Then after I orally anticoagulate them, I have 2 options here. Let's say that I want to be a little extra, okay? I have a person who's been in AFib for more than 48 hours or an unknown time period. They have a high risk of a CVA. I get an echo. I see a left atrial thrombus. I orally anticoagulate them for 3 weeks. What I can do is I can recheck their TEE after those 3 weeks and see, is there still a left atrial thrombus? Because there is, then I might have to anticoagulate them maybe a little bit longer or move to this next step. But let's say that you do it. Let's say that you go this way. They have high risk, you get an echo, they have an atrial thrombus, you anticoagulate them for 3 weeks, you recheck their TEE, and then they have no left atrial thrombus anymore. Then what do? Then you can cardiovert this patient and you can put them on oral anticoagulants for about 4+ weeks. And maybe you have to continue it long term because of them having high risk of further embolization. But either way, look what you can do here. Ready? You can get, if they have AFib for more than 48 hours, unknown time period, high risk of stroke, you get a TEE, positive left atrial thrombus, you orally anticoagulate them, recheck the TEE after that, and then if they have a negative thrombus, you can cardiovert them and then anticoagulate them after that for 4 weeks. Or if they have AFib for more than 48 hours or an unknown time period, high risk of CEA, you can orally anticoagulate them empirically. Then after you do that 3 week, cardiovert them and then anticoagulate them for 4 weeks or more. That is how we go about kind of the algorithmic approach of treating atrial fibrillation. Now, let's take a little bit of time talking about the depths of rate control, the depths of anticoagulation, and the depths of cardioversion. All right, so now let's talk about rate control. Rate control, what are we doing with rate control and why is it actually helping us? The whole concept is, take here, you have your conduction system, right? Your SA node, your AV node, your bundle of His, your bundle branches, Purkinje system, all that stuff, and we kind of zoom in on it. We want to focus on this AV node, right? When we give drugs like rate control agents, what they're trying to do is they're trying to block the actual electrical activity that's coming from those ectopic foci or from those particular reentrant circuits from moving through the AV node and then down into the actual bundle of His, Purkinje system, all that stuff that's causing the rapid ventricular rates. We want to block that. If we block that, we basically kind of sift through all of the excess electrical activity and only allow for certain things to go down to the ventricles, which should slow down the ventricular rate a little bit, right? That's the goal. So what are drugs that can block this AV node? Well, the first one is we can use things called beta blockers. And if you want an example of that, think of something like metoprolol. This is a very commonly utilized drug, metoprolol. The next one, now real quick, because they might ask this on your exam, what would be a contraindication to giving metoprolol? It shouldn't always be like this, but it's sometimes a person who has a reactive airway disease, they have underlying COPD. Because it is a beta blocker, there's beta 2 receptors in the lungs, so if it interacts with that, it may cause bronchoconstriction and potentially exacerbate their condition. So that's something to think about on your exam. The next one, in pink here, calcium channel blockers. So calcium channel blockers, they block the calcium channels in those AV cells, blocking calcium entry that slows down the electrical activity that's being transmitted through the AV node. What is a common drug? There's 2 types, but the more commonly utilized one is what's called diltiazem. So diltiazem is going to be another type of calcium channel blocker. There's also verapamil. What is a potential contraindication to giving diltiazem that they may ask you on the exam? If they have decompensated heart failure, you should try to stay away from calcium channel blockers. These are your 2 preferable agents. The third line one that you can use, it just takes a little bit longer to kick in, is digoxin. Digoxin actually is a very weird drug, and it actually targets what's called sodium potassium ATPases, which alters some calcium sodium exchangers. But either way, this is a drug that is good if they have hypotension or heart failure. It's kind of a preferable drug because you also get increased contractility from this drug. So that's another thing to think about for your exams. The last one, which is your third line agent, is amiodarone. So amiodarone is a very interesting drug because this one has both rate control effect and rhythm control effect, but it's actually kind of one of the ones that are a little bit more hemodynamically stable kind of drugs. So to give you a quick concept here in purple, this would be your beta blockers. They're blocking the epinephrine, norepinephrine from binding on here, and the whole effect is you're kind of trying to decrease like the calcium entry, right? Particularly the calcium channel blockers, they're blocking the calcium entry into the actual muscle cell. This amiodarone, it actually does a couple things. It blocks sodium entry and it blocks calcium entry, and it actually has a little bit of beta blocker effect. So you can actually get 3 effects from amiodarone: a beta blocker effect, a calcium channel blocker effect, and a sodium channel blocker effect. The digoxin is the one that's really weird, man. It loves to stimulate the vagus nerve, which is cranial nerve 10. That's your parasympathetic nervous system. If it stimulates your parasympathetic nervous system, that causes an increase in acetylcholine. If you increase your acetylcholine, right, what would that do? What would that do? That would slow down your heart rate, right? That would slow down your heart rate. So if that slows down your heart rate, what would digoxin want to do to that? Stimulate that, increase the acetylcholine release, cause more potassium to leave the cell, and then again, lower down your heart rate. So that's its effect on the AV node. Its effect on the contractility effect is the sodium potassium ATPases and the sodium calcium exchanger. So make sure that, I wanted to make sure I separate that. So the effect on how it works on the AV node is stimulating the vagus nerve via the parasympathetic nervous system effect. Okay? All right, these are the drugs that we utilize for rate control. It's the first step there above. Okay? Rhythm control, okay? Since we're here, it is the third step, but we're going to talk about it since it's ease of access in this part of the board. Rhythm control, that's kind of that third step, which we're determining cardioversion. There's 3 ways that we can kind of control someone's rhythm. The first one is we can utilize drugs. So we can utilize particular types of drugs or, chemicals. We can use what's called chemical cardioversion. And my gosh, is there so many different types of chemicals that we can use. We are not going to list them all. We'll have a separate lecture that focuses on all of these antiarrhythmic agents. But you have different drugs like type 1A, like procainamide. You have drugs like type 1C, like flecainide and propafenone. You have drugs like type 3, okay? And this gets into things like abutolide and amiodarone and all these different types of other drugs. But these are ways that we can kind of alter the activity of different types of channels, like sodium channels and potassium channels, altering their activity, which in a way helps to regulate some of the electrical activity within the myocardial cells of the atria, and then again, helping to regulate that rhythm. So there's chemical drugs. The only thing that you want to remember about this that they may ask on the exam is that these can potentially, some of them can potentially affect the QT interval and therefore increase your risk of what's called torsades de pointes. This may come up on your exam that you should know about. The other option is we can just shock the crap out of the heart, right? We can apply electricity. So the other option is we do what's called electrical cardioversion. So electrical cardioversion. And the whole idea with this is that you're trying to basically shock the heart, reset all the electrical activity of the entire myocardium so that you can get them back into a normal sinus rhythm. Okay? The last one here that you want to be thinking about, though, is radiofrequency ablation. So this is kind of like getting into the last aspect, where maybe you've tried some chemical cardioversion, you've tried some electrical cardioversion. You can utilize radiofrequency waves, so radiofrequency ablation, to kind of destroy some of these agitated, irritable, ectopic atrial foci. You know where they most commonly love to sit? Around the entrances of the pulmonary veins in the atria. So in the entrances of the pulmonary veins, you'll kind of take this like little thing here, this catheter, and shoot radio waves and burn those ectopic areas so that they're not existing anymore, so they can't generate those abnormal rhythms. So that's something that you can do, something called radiofrequency ablation. And the big thing to remember is that this is usually near the pulmonary vein entrances. Another option that kind of goes along with this one, so you can have radiofrequency ablation. A second one that it can come up on your exam to think about. It's a surgical procedure where you do what's called the maze procedure. This is an actual surgical procedure. Usually if they're getting some type of cardiac surgery that's going to be done, then you can do a maze procedure as an option. But generally RFA would be the first line thing before you go to a maze. Okay, so rhythm control, we can do it with drugs, we can do it with electricity, or we can actually burn it, or we can cut it, okay? The last but not least thing to talk about is anticoagulation. So atrial fibrillation, right? We already kind of have an idea here that these patients are at high risk for forming clots and embolizing some of those blood clots to different areas within the body. So the way that we determine their need for anticoagulation is utilizing this score called the CHADS-VAS score. So the CHADS-VAS score is a way that we can risk stratify. So to use that, it's a way that we can kind of risk stratify and determine the patient's need for anticoagulation, okay? Big thing that I want you guys to remember is you should also correlate this test, the CHADS-VAS score, which is determining their need for anticoagulation, compare it. So it should go against, you should compare this with the score called the HAS bled score. And this determines their risk of bleeding. So you should have both of those, determining what's their need for anticoagulation and what's their risk if they're on anticoagulation that they bleed. So it can kind of give you an idea of what, risk versus benefit and stuff like that. Anyway, knowing this, how do we kind of calculate this? Well, there's particular things that this is kind of an acronym. It tells us what we know, right? What we need to know. So CHF is one, okay? Hypertension is another one. Age is another one. Now this one, at this point in the age, there's two A's and they both mean age. This is greater than 75 years of age. D is for diabetes. S, so this part here is if they've had some type of recent stroke or maybe even a TIA. V, if they have some type of vascular disease. What does this mean? Do they have peripheral artery disease? Do they have some type of coronary artery disease of some kind? Do they have a valvular heart disease? They have a vascular disease of some kind. The next one, you got another age. This one is generally anywhere from 65 to 74 years of age. And then S is for sex, okay? And particularly this is obviously you have female and male. Now, how do we score all of these things? You can kind of utilize these numbers here to tell you what you need to know. Okay, so first things first. You have here the C. There's no 2 in front of or behind it, or a subscript, right? So that's only 1 point. So if you have CHF, you get 1 point. Hypertension, there's only no subscript of a 2 there, so you only get 1 point if you have that. Age, 75 greater than that. So if you're greater than or equal to 75, that gets you 2 points. Diabetes, there's no 2 there, so that gets you 1 point. If you've had a stroke or TIA, that gets you 2 points. If you have vascular disease, that gets you 1 point. If you have an age of 65 to 74 years of age, that gets you 1 point. And if you have a sex, particularly female, that gets you 1 point. Male is 0. Okay? So that will give you all that you need to know. Now, let's say that you do this. You calculate all of this. Once you've calculated a person's CHADS-VAS score and you've compared it with their HAS-BLED score, let's say that their score is 0. Do they need to be anticoagulated? No, not really. They're kind of low risk. So really there's no anticoagulation that's needed. Now obviously this is dependent upon provider to provider. They may see other potential needs for them to have to get on anticoagulation, but by definition, no, they don't really need anticoagulation. Score of 1, it's plus or minus. Again, it kind of goes based upon their risk factors, their medical condition, thinking about other things that they may need. So plus or minus anticoagulation for a score of 1. Okay, so as you can put, it's possible. But again, you have to utilize your HAS-BLED score to see, okay, is the risk, of them being on this going to be problematic, or is the benefit of being on anticoagulation going to outweigh the risks? The last one, if they have a score of greater than or equal to 2, anticoagulation is needed. Okay, so anticoagulation is needed. Now, here's the thing. You got to be thinking about this. If, let's say that they had a person who had a score of 2 or plus, 2+, right? Their Has blood score was really high though. Frank, what do I do? I don't know what to do. I don't know if I need to anticoagulate this person. What if they have a bleed in their brain or something like that? They need anticoagulation. They have high risk of forming strokes. What do I do? What do I do? In some kind of situation where you kind of run into this issue, you lead into this next option, which I really think it's important that you guys know. There is something where they can do something what's called a Watchman device. And basically what they do is if someone can't be on an anticoagulant, but you need to have some way of preventing them from forming clots, they go in and they kind of occlude out the left atrial appendage where you commonly form clots. And it's a way of kind of having some type of anticoagulant or anti-embolic kind of activity without actually being on a drug that puts them at risk of forming clots. So something to think about. Now, we've done the CHA2DS2-VASc score. We risk stratified. We know whether or not they need anticoagulation. We compared it with their Has bled. We said, ooh, they need to be on anticoagulation, but they have other features that would prevent them or contraindicating them from being on them. That's where the Watchman device comes in. The last thing we have to talk about is which drugs do we utilize for anticoagulation and why are these drugs picked? We're not going to make it hard. Warfarin, this one is good for someone who has a valvular AFib, or if they have chronic kidney disease, or they have liver disease. So if they have liver disease, they have chronic kidney disease, or they have a valvular AFib, warfarin is kind of like your go-to in this scenario. The only thing that you have to remember is that when someone's on warfarin, you have to monitor their INR and do your best to keep it within a 2 to 3 range. If it's below, they're still at risk of clots. If it's above 3, they're at risk of bleeding. So that is a thing to think about with warfarin. All right, DOACs is a second option. Now DOACs is kind of a direct oral acting anticoagulants. There's 2 categories. You have your factor 10A inhibitors. So this is things like rivaroxaban and apixaban, adoxaban, all of those. And then you have your 2A inhibitors. And this is things like dabigatran. Any of these are generally good for someone with a non-valvular AFib. Okay? They're good for someone with a non-valvular AFib. You can prescribe this one, okay? Also, you can do it if they're in the hospital as well. These have a kind of a lower risk of bleeding in comparison to warfarin, which you can have higher risk of bleeding from. The last option, okay, so we got warfarin, we got DOACs, and we got heparin. Heparin is really a good drug, especially in the hospital. And this comes in, you have what's called unfractionated heparin, or you have what's called low molecular weight heparin. Either way, the nice thing about these drugs is they're good, they're easily titratable. Very easily titratable, which is good whenever you have someone in the hospital and you're really trying to control their actual anticoagulation status. The way that we prefer to monitor very specifically unfractionated heparin is you utilize what's called its PTT. There's also like anti-XA activity, but PTTs is a good way to kind of say, are we within the range that I want heparins? Because if it's too high, I got to lower the dose. If it's too low, I got to increase the dose. So it's easy to really, really titrate. Okay, so heparin is good in that situation, and also it's also good as a bridge. So whenever somebody is on warfarin, they're hypercoagulable for a small period of time, so they can get kind of like what's called clots and stuff, like warfarin-induced skin necrosis. So generally, you put them on heparin for a little bit of time to bridge them through that hypercoagulable state, so that they can get into a state of where they can prevent clots for a little bit. Okay, so I know it seems like paradoxical, but yeah, heparin is a good bridge while they're in the hospital, and then when you go outpatient, you can bridge them into a DOAC or you can bridge them into warfarin long term. So it's a good drug. It's also very good in pregnancy as well. So that covers our atrial fibrillation topic. All right, Ninja Nerds, in this video we talk about atrial fibrillation. I hope it made sense. I hope that you guys enjoyed it. As always, Ninja Nerds, until next time.